students, in this session we are going to discuss a very important RNA virus, that is poliovirus. So poliovirus, which belongs to the Picornaviridae family. So before going to poliovirus, we'll just see a classification of RNA virus. So the RNA viruses, which you may be familiar with, what we have dealt in separate sections are HIV virus and the hepatitis viruses, except hepatitis B virus. So we'll see a classification of RNA virus. If it can be asked as a question, classify RNA viruses. This seems a little complicated, but we'll pick the only things which we require. You can simply classify RNA viruses into single-stranded RNA virus and double-stranded RNA virus. And among the single-stranded RNA viruses, you again have a classification as positive sense RNA virus and negative sense RNA virus. Even if you find it difficult to memorize that, you can just omit the sense positive and negative. You can just remember single-stranded and double-stranded RNA. And among all the RNA viruses, the only RNA virus which is double-stranded is a reoviridae. So this is the only double-stranded RNA virus which is a non-enveloped virus. Double-stranded RNA virus which is non-enveloped is a reoviridae. And among the single-stranded RNA, all other RNA viruses are single-stranded. Single-stranded RNA viruses, the only non-enveloped single-stranded RNA virus is Picornaviridae and Calciviridae. So among the RNA viruses, the double-stranded RNA reoviridae, which includes the famous diarrhea-causing virus rotavirus, is non-enveloped, and among the others which are single-stranded, the two known enveloped viruses are Picornaviridae and Calciviridae. And now I hope you might be remembering in DNA viruses, the non-enveloped DNA viruses were parvovirus, papillomavirus and adenovirus. All other DNA viruses were enveloped. And in RNA viruses, you can remember like this PCR, Picornaviridae, Calciviridae and reoviridae. All these three are non-enveloped. Okay, then you can learn what are the enveloped viruses. So it is easy, all others are enveloped. Enveloped viruses, you have Coronaviridae, Flaviviridae, Toga, Retroviridae. That is your HIV virus comes in Retroviridae. Togaviridae includes the chikungunya virus. Flavi includes dengue and Japanese encephalitis. Coronaviridae, you know what are the coronaviruses. You have a list of coronaviruses which are discovered in the order of the discovery, like the recent ones you can remember SARS coronavirus, MERS coronavirus and the recent SARS coronavirus 2. Okay, then coming to the other enveloped single-stranded RNA viruses, orthomyxovirus, paramyxovirus, rhabdovirus, filovirus, bunyaviridae and arenaviridae, of which you can remember orthomyxo includes influenza, paramyxo includes parainfluenza, measles and mumps, rhabdovirus includes rabies virus, and the others are actually emerging viral infections, filoviridae, arenaviridae, which contain viruses causing hemorrhagic fever. So at least you can remember a single-stranded RNA and double-stranded RNA. Double-stranded RNA, there is only one, that is the reoviridae, and single-stranded RNA, you have enveloped and non-enveloped ones. The non-enveloped ones are Picorna and Calci, and all others are enveloped, including Corona, Flavi, Toga, Orthomyxo, Paramyxo, Rhabdo, Retro, Philo, and all. Okay, and the only double-stranded DNA, which is a non-enveloped virus, is a reoviridae. So this is the classification. Just make a list of the single-stranded, double-stranded, enveloped, and non-enveloped, and you'll be able to recollect it for exam. So coming to the Picorna virus group, which includes poliovirus. So Picorna virus, it has the most important virus included in it, that is poliovirus. Picorna is a single-stranded RNA. All of them are single-stranded RNA, and Picorna is non-enveloped. That's what we have seen. PCR, Picorna, Calci, and Rio are non-enveloped. We can classify Picorna virus into different genera, including enterovirus, paracovirus, rhinovirus, and hepatovirus. You see, hepatovirus includes hepatitis A virus. So in hepatitis A virus, we have seen that it belongs to Picornaviridae family. Rhinovirus, it causes the human common cold. The common cold we normally get, the most common virus causing common cold is rhinovirus. And Paraco is also a less important virus, but we can concentrate on the enterovirus group. Why it is called enterovirus? Now you know entero means related to enteric intestine. So you get the infection through the oral route by ingestion. So this includes poliovirus, Coxsackie virus A and B, and there is echovirus, and there are various enteroviruses named after numbers like 70, 71 and all. So you can remember the viruses coming under enterovirus and Picornaviridae family: polio, Coxsackie virus and echovirus. Then you have a separate genus called paracovirus, rhinovirus and hepatovirus. And which is the hepatitis virus that is coming under the Picornaviridae family? That is hepatitis A virus. So all these can be asked as MCQs. Coming to polio, poliovirus is the causative agent of the famous disease paralytic poliomyelitis. Recently, in our country, we have almost reached the verge of eradication of polio. Like the last case was reported a very years back, and now we don't have active cases of polio. We only have cases of paralysis, which is associated with vaccine. Otherwise, we don't have any wild cases of polio. Poliovirus strains are classified into types 1, 2 and 3. This one is comparatively a smaller virus. It has a single-stranded RNA. It is non-enveloped. And the pathogenesis, coming to the disease pathogenesis, children are more susceptible. We can read about the history of polio, how it was affecting mankind at one point of time before the discovery of vaccine. It was such a disease which leads to paralysis and various sequelae which made their life very difficult. So that was once upon a time polio was such a disease of disaster that was affecting mankind, but now we have very good vaccines that has helped us to come to an eradication stage. The mode of transmission of poliovirus is by ingestion, or you can call it as a feco-oral route. Feco-oral route, because this virus, it goes to intestine, it is excreted in the feces, and you can get the infection by feco-oral route. And how the disease causes paralysis, that is something interesting because it reaches intestine, it is by ingestion, and how it is going to CNS. So it comes through the oral route, it multiplies in the lymphatics of the oropharynx and intestine, then it will enter the bloodstream. Through the lymphatics, it go to the bloodstream, and through bloodstream, it will reach the CNS. And in CNS, the favorite area for poliovirus is the spinal cord. The anterior horn cells of spinal cord is the favorite area for poliovirus. It will cause damage to the anterior horn cells of spinal cord, and that is why it causes this paralysis and sensory deficits. So the early manifestation of a patient who has polio, it is fever, malaise, sore throat, because it's entering through the oral route. You will have some systemic flu-like symptoms like fever, malaise, headache, drowsiness, sometimes constipation and sore throat. This may last for 1 to 5 days, after which you will develop the infections. In some people, it will be inapparent infection. You don't have any symptoms. In some, it will be non-paralytic polio. They will be just having an aseptic meningitis. Because this virus, when it is penetrating the CNS, it will be first affecting the meninges, causing aseptic meningitis. But in others, it will lead to paralytic poliomyelitis. It leads to flaccid paralysis of the limbs. So that is the most severe form of the disease, paralytic poliomyelitis. Now, for diagnosis, polio, it is mostly, if it is a paralytic polio, it is mostly a clinical diagnosis, but at times you have to confirm it is polio. So the specimen that you're going to take is the feces sample, because the virus is excreted in the feces. So it can be demonstrated in stool by direct electron microscopy or by immunoelectron microscopy. So till now you have seen many viruses, and now you know for direct visualization of virus in fecal sample, you can go for an electron microscopy or immunoelectron microscopy. Otherwise, if the virus produces inclusion bodies, you can use a light microscopy, or else to see the virus structure, you require electron microscopy. Now, if you want to isolate poliovirus in culture, you can use the primary monkey kidney cells. It is primary monkey kidney cells, okay, or HeLa cells and Hep2 cells can be used for virus culture. So then there are PCR tests available, molecular tests are available, serological tests are available, but all those are All those can be used for diagnosis. So coming to the most important part of this topic, which is always asked, is the prophylaxis. This is a short note which is always asked: polio prophylaxis. So for prophylaxis of polio, we have a very good vaccine. Actually, we have two types of vaccine discovered by two famous personalities, the Salk vaccine and the Sabin vaccine. This is named after the persons who discovered the vaccine. It was the Salk vaccine that was first discovered, then came the oral polio vaccine, Sabin vaccine. These vaccines are the landmark discoveries in the history of polio, which has led to the control of this very dangerous disease, and we have almost reached the eradication stage. So how you can remember, one vaccine is a killed vaccine and the other is a live vaccine. So Salk vaccine is the killed vaccine. That is how we can remember. And Sabin vaccine is a live vaccine. So what is left is Sabin. Sabin is the live attenuated oral polio vaccine. So we are going to see the most important part of this topic, that is called the prophylaxis, how you prevent polio. So we have specific prophylaxis measure for polio in the form of two vaccines. So this is a very frequently asked question, the prophylaxis of polio. You have to learn about two types of vaccine which is used. So these two vaccines are named after the persons who discovered this. That is a killed polio vaccine called Salk vaccine and live attenuated polio vaccine called the Sabin vaccine. So both these discoveries were the landmark discoveries in the history of polio virus, and that has led to the control of this epidemic, which was once a very dangerous disease of mankind, and now we are almost reached the stage of eradication. This is just because of these two vaccines. And how you can remember which one is the killed polio vaccine and which is the live vaccine? Salk discovered the killed vaccine, so there is a K here. So you can remember Salk vaccine is the killed vaccine. So what is the other one, which is Sabin vaccine? That is the live attenuated oral polio vaccine. So Salk vaccine is a killed vaccine. You give it as injection, and Sabin vaccine is a live vaccine. You give it as an oral vaccine, as drops. That is what we use every year for the pulse polio immunization program. Salk vaccine, you have to give 3 doses, 4 to 6 weeks apart. That is a schedule for the killed vaccine or inactivated polio vaccine, and you have to give a booster 6 months later. This is how you have to give the IPV. You call it in short as IPV, inactivated polio vaccine or injectable polio vaccine. So IPV is actually standing for injectable polio vaccine. So when you say injectable polio vaccine, we mean it is the killed polio vaccine or Salk vaccine, and that you are giving it as a 3 dose with a booster. Coming to Sabin vaccine or live attenuated oral polio vaccine, how will you abbreviate this? You can call it as OPV, oral polio vaccine. So the other one was IPV, this is OPV. This is administered orally. You give it in 3 doses. How will you give the doses? Actually you need a 0 dose. In India, in our national schedule, ideally it is recommended to be 3 doses, but in our schedule we give a birth dose also. It is called the 0 dose. Immediately after birth, you give oral polio vaccine to all children born in our country, and that is called the 0 dose of OPV. Following this, you give 3 more doses at 6 weeks, 10 weeks, and 14 weeks. So you give 3 more doses at 6 weeks, 10 weeks, and 14 weeks along with DPT. So OPV is repeated every 4 weeks, that is 6 weeks, 10 weeks, and 14 weeks along with the DPT vaccine. After that, you give a booster dose at 16 to 24 months. So that is also along with the DPT vaccine. So you have a 0 dose, you have again 3 doses at 6 and 14 weeks, and then you give a booster at 16 to 24 months. Now this is the very important thing, Sabin versus Salk vaccine or IPV versus OPV vaccine. Difference between these two. If you learn this table, it is very good because it's always asked. If the question is prophylaxis of polio, or if they ask difference between IPV OPV, you can remember 4 or 5 points of the difference. So what is the basic difference between IPV and OPV? IPV is a killed vaccine and OPV is a live attenuated vaccine. And how do you give IPV? You give it as injection. You can either give a subcutaneous or you can give intramuscular injection. OPV, you give it as an oral vaccine. It's given as drops, oral polio drops. Now, if you give an injection, it will induce humoral antibodies. It will induce antibodies in circulation. but there will be no mucosal or local antibodies. Like if you get a poliovirus infection, it enters through the oral route, it will induce immunity in the local mucosal tract, in the GIT, in the upper GIT, it will induce mucosal immunity in the form of IgA antibodies. But this can happen only if you give a oral polio vaccine. If you give an oral polio vaccine, it is a live attenuated vaccine. It behaves exactly like how the live virus behaves. So it goes through the oral route, it reaches the intestine. It will elicit the intestinal mucosal cells to produce IgA antibody. So what is the advantage of this is, this will prevent us from getting an infection. Otherwise, if you have a humoral immunity, that's just antibodies present in the circulation, it will only neutralize the virus when the virus enters the bloodstream. Otherwise, it cannot prevent an infection because infection comes through the oral route. So, IPV will induce the circulating antibodies, but it won't induce local or intestinal immunity, whereas OPV can induce both humoral and intestinal or local or mucosal immunity. We have learned that in immunoglobulin class, mucosal immunity or local immunity is induced by IgA antibody. So, that can be possible only with oral polio vaccine. So IPV it's producing antibodies in circulation, so it can prevent paralysis associated with polio, but it does not prevent infection because there is no local immunity. It won't prevent infection, but once the virus enters bloodstream, it can neutralize it, so it can prevent paralysis. But OPV will prevent paralysis and also it will prevent reinfection because of local immunity with IgA. Okay, and IPV cannot be used, it's not useful in controlling epidemics, whereas OPV can be effectively used in controlling epidemics because it's a live vaccine and it will induce local immunity. And IPV is very difficult to manufacture and is relatively costly, whereas OPV is easy to manufacture and is cheaper. But the other thing is IPV has got certain advantage because it does not require stringent conditions because it's a killed vaccine. You can easily store it and easily transport it. It has a longer shelf life, whereas OPV, it has to be stored and transported at sub-zero temperatures. You have to be very strict in the storage conditions, otherwise it will be easily damaged. So that is a disadvantage with OPV. And another disadvantage with OPV is OPV can induce vaccine associated paralytic polio. Because this is a live vaccine, at times it can, if the attenuation is not proper, it can lead to paralysis in the vaccinated individual, but this is very, very rare, but still it has a risk of such a complication, vaccine associated paralytic polio. But this one being a killed vaccine, it is safer. No risk of any kind of adverse effects for IPV. So these are the differences between IPV and OPV. So IPV, OPV, basically IPV is a killed vaccine. This one is a live attenuated vaccine. How do you give IPV? You give it by injection as subcutaneous or intramuscular injection. This is oral. And what kind of immunity does IPV produce? It won't produce no local immunity, whereas OPV has local immunity or mucosal immunity. So IPV prevent paralysis. It will not prevent infection, but OPV can prevent infection and paralysis because it is producing local immunity. And then what else is the advantage of IPV? IPV, does it have any advantage? IPV, actually it is easy to store and transport, easy to store because it is stable. Since it's a killed vaccine. This one, it is very difficult. You need strict storage conditions is required for OPV and it will be easily damaged. It's because it's an oral vaccine, it is easily damaged. And which one is more safer? IPV is more safer. This one has the risk of VAP. And if you consider the cost of the production, this is costlier. IPV is actually costlier and this is cheaper. So you have to remember 4 or 5 points from between the difference between these two, and that will help you in writing for the exam. You can make your own points. So basically OPV is a better vaccine. The only problem with OPV is it will induce vaccine associated paralytic polio in like 1 in 1 million or 10 million cases. Very rare, but still there is a risk. Comparatively, IPV is safer, but in all other aspects, it is inferior to OPV because there is no local immunity. You cannot give it for epidemics. It is costlier and it won't prevent infection. So all those things. Okay, but the storage wise, it's better to have an IPV. It's easy to store because it's a killed vaccine. So these are the differences between IPV and OPV. So we have learned polio virus in this class, which belongs to Picorna viridae. So Picorna viridae, you have an RNA in this Picorna. So this is an RNA virus, don't forget that. And please be very thorough with the prophylaxis of polio, your two kind of vaccines, IPV and OPV. This is very, very important. The differences you can make a table and learn, always ask for exam. So that is about the polio virus. Thank you.